Hi, my name's Sindy Yang.
My name is Anna Liu.
I'm Nathalie Brown.
And I'm Katie Meehan. We did our presentation on psychopharmacotherapies in pediatric patients. Mental health is an important part of children's overall health and well-being. There are rising mental health needs and disparities among children and student groups, and a perceived stigma which acts as a barrier to people receiving needed services. According to the Department of Education, as mental health has become an increasing topic of discussion, we currently are faced with challenges of ineffective implementation of practices, a gap in professional development and support, and a lack of access to usable data to guide implementation decisions. So how prevalent are mental health disorders in children? According to the CDC, 1 in 5 children are diagnosed with a mental disorder. Only 20% of the children diagnosed actually receive help from a specialized care provider for mental health. 9.4% of children are diagnosed with anxiety, and about 6 in 10 of these children receive treatment. 9.8% of children are diagnosed with ADHD. 4.4% of children are diagnosed with depression, and about 8 in 10 of these children receive treatment. About 3 in 4 children that are diagnosed with depression also experience anxiety. About 8.9% of children are diagnosed with behavioral problems, and about 5 in 10 of these children receive treatment.
Children's experiences in school. Due to healthcare-related needs, such as ADHD, autism, and other related disorders, children in school start to experience barriers in their mental, social, and behavioral development. These barriers can come in all different forms, especially interaction with other children their age. As a result, this may lead to future psychological issues due to depression or other health concerns. Being able to socialize with others is an important part of their development for children in school. As the U.S. Secretary of Education Miguel Cardona said, our efforts as educators must go beyond literacy, math, history, science, and other core subjects to include helping students to build their social, emotional, and behavioral skills as they need to fully access and participate in their learning and make the most of their potential and future opportunities. And she continues to add, in the midst of the pandemic, we know that our students have experienced so much. We can't unlock students' potentials unless we also address the needs they bring to them to the classroom each day. As educators, it's our responsibility to ensure that we're helping to provide students with strong social and emotional foundation as that they also can excel academically.
Many children and students struggle with mental health challenges that impact their full access to and participation in learning. And these challenges are often misunderstood and can lead to behaviors that are inconsistent with school or program expectations. The COVID-19 global pandemic intensified these challenges, accelerating the need to provide school-based mental health support and leverage our accumulated knowledge about how to provide nurturing educational environments to meet the needs of our nation's youth. The pandemic caused school closure as well as shutting down of other programs and private practices, which decreased students' access to many mental health resources. When the pandemic first started, a sense of fear and uncertainty took over the population. As the pandemic continued, the chronic stress led to more frustration and anger towards the constraints. These constraints included the inability for many people to partake in activities that had become a normal part of life. For instance, there were no sports, gyms, and malls were closed, and people were trapped indoors. The lack of interaction and access to many resources resulted in increased strain on people's mental health.
Psychotherapy is the cornerstone of pediatric depression treatment. Medications are only needed in certain cases but are used in adjunct with psychotherapy. Some pediatric psychopharmacotherapy include SSRIs, which are used for depression and OCD by inhibiting the reuptake of serotonin, and also mood stabilizers, which work by decreasing abnormal activity in the brain, which are used for bipolar diseases, aggression, and self-injurious behaviors. Pharmacotherapy is recommended for patients with moderate or severe depression. Tricyclic antidepressants are not effective in children and adolescents. Antidepressants have a black box warning for increased risk of suicide. Therefore, careful assessment, follow-up, safety planning, and patient and family education should be included when treatment is initiated. For medication comparison, SSRIs are generally the first-line medication for depression in children and adolescents because most people only have mild or no side effects. The medication is generally taken once per day, which increases adherence. Side effects can include headaches, abdominal pain, diarrhea, nausea, sleep changes, jitteriness, and agitation. Second line is atypical antidepressants. However, they do have more side effects. Other than venlafaxine, these medications have not been well studied in children and adolescents. Tricyclic depressions are not used in the pediatric population. They have been shown to not be effective and are generally avoided due to their cardiac risks. For the treatment of ADHD, there's two options. You could use stimulants like methylphenidate products, which include Concerta, Ritalin, Quilichu ER, or amphetamine products like Adderall. And then there's the non-stimulant route like atomoxetine, guanfacine, and clonidine. There are many different treatments options available. Treatment options will vary on what is best for each child's need. The goal of treatment is to improve impulsivity, hyperactivity, and inattentiveness. If the family does not think that medication is an appropriate route, non-pharmacological options like family-focused interventions can be used. Family-focused interventions use behavioral parent training for parents to implement in the child's life. This includes behavior modification for the parent to implement at home. This includes things like positive reinforcement, taking away rewards when negative behaviors are present, and using timeouts. According to the American Academy of Pediatrics, first-line therapy for ages 4 to 5 is non-pharmacological treatment, and for ages 6 to 18 is methylphenidate products or amphetamine products. Second-line therapy for ages 4 to 5 is methylphenidate products, and for ages 6 to 18 is atomoxetine, guanfacine, or clonidine. The goal of treatment is once again to improve attentiveness, hyperactivity, and impulsivity.
Adding non-drug therapy options for pediatric patients. Considering non-drug therapy options for pediatric patients is very important for children's long-term health. There is still not enough data and strong enough evidence-based information to disregard pharmacological treatment and only do non-pharmacological adjustments. However, there are still long-term adverse effects on relying solely on drug therapies at a young age, which may lead to an increase in medication dependence as they get older. As a result, side effects from current pediatric psychotherapies may lead to more disorders in the future due to the reliance and more issues if they are not used properly. In addition, one of the biggest concerns in the prescription medications world is overtreatment in the pediatric population.
When considering psychopharmacotherapies in pediatrics, it is important to weigh the benefits and risks. Benefits of medication use is that it aids in relieving current symptoms. Use of cognitive behavioral therapies have shown proven benefit to symptoms. If the child gets the adequate treatment needed, it avoids the severity or duration of episodes. It prevents residual symptoms, negative cognitive style, comorbidities, psychosis, and suicidality. Considerations to make while considering medication use are increased risk for suicide ideations, development of mental health complications, increased risk of depression and other disorders, adverse drug events such as insomnia, fatigue, sedation, restlessness, and increased risk aggregation.
Next, I'll be showing a study comparing antidepressant usage in 2007 to 2014. The participants are youth under 20 years old who were continuously enrolled during each study year in a Mid-Atlantic state Medicaid program. Table 1 shows the prevalence for antidepressant use comparing 2007 and 2014. Any antidepressant usage changed from 2.65% to 2.74%. Any SSRI and SNRI usage was 1.88% and it increased to 2.14%. TCA usage increased from 0.21% to 0.23%. And other antidepressant categories actually decreased from 0.92% to 0.78%. These show an increase of any usage of antidepressant usage. SSRI and SNRI usage also increased. There was a slight increase in TCA, but a decrease in other antidepressants used. Now looking at another table, it breaks it down by age group, gender, race or ethnicity, and other categories. Looking at this table, we can see that the usage of antidepressant from 2007 to 2014 was that the older the child gets, the more antidepressant prescriptions is used, with the highest being in the age range of 15 to 19 and the second highest in the age range of 10 to 14. The increased usage of antidepressants in females as compared to a decrease in males. The increased usage in the Black race and others compared to white in race and ethnicity. Under different eligibility requirements such as foster care, supplemental security income, and income eligible, there was an increase of antidepressant usage. In conclusion, there has been an increase in antidepressants over the year, which can increase potential for overtreatment in the pediatric population.
Encouraging school systems to raise awareness of mental health and the acceptance of other disorders. In schools, we prioritize three critical and interrelated components of mental health: social, how we relate to others; emotional, how we feel; and behavioral, how we act, supports to promote overall well-being. Children spend the majority of their adolescent lives in the school system. Integrating mental health resources and curriculum into school systems increases accessibility. In order to decrease stigmas against mental health, it is important to educate staff, parents, and students on the symptoms and signs of mental health problems. Developing effective programs can help normalize mental health discussions and create a more accepting environment. The CDC has taken action and implemented behavioral health integration to improve access to mental health resources for children and families. This usually involves collaboration between primary care providers and specialized care providers for mental health, making it easier for primary care providers to include mental health and behavioral health screening, treatment, and specialty care into their practice. This collaboration could result in better outcomes for the youth, more efficient coordinated care, higher treatment rates, reduced parental stress, and improved consumer satisfaction. Thank you for listening to our discussion today, and please let us know if you have any questions.